Oh, hi, Graham. How's
Oh,
it going?
hey, Dr. Harrison. It's okay. So this is this is Mr. Stephen Johnson. He's a guy with end-stage renal on hemodialysis. You know, he's normally systolic, he's in the 180s. He was intubated in the emergency department with respiratory distress and what they were pretty sure was sepsis. You know, his temperature was 39.2, and right now his vitals have not gotten any better. His heart rate's in the 120s, his SAT's 94, his blood pressure, this is actually the worst his blood pressure's been, 68/38. And you know, he's not overbreathing the vent, he's sedated. We tried to get a central line in him earlier, but we couldn't get one to flush. And so we did get a PICC line in him. I've got phenylephrine running for his blood pressure, but it's really not working.
Okay. Yeah, I agree. This guy, he's already got his antibiotics.
Yeah, he got Zosyn and vancomycin.
Okay, so his BP looks like you said, it's worse than it was. It's actually getting pretty low. I think we're gonna have to escalate to epinephrine.
Okay.
Larry, why don't you order an epi infusion from pharmacy?
Sure, Dr. Harrison.
And as soon as you finish that, could you please dilute epi down to 10 mics per ml?
Yes, I'll work on that.
Graham, we may need to bolus him.
Yeah, I agree.
Infusions get up.
So
she's getting pretty low. Is that? It looks like he's coming up with 68/40.
Yeah.
That's pretty.
That's the
sudden
lowest he's
decline
been. Yeah.
that it's happened. All right, Larry. I think we're going to need to call for more help. This patient's becoming acutely more unstable.
Do you want me to call a code?
He's actually pretty close to that. I think it's the best choice to get more
Yeah,
help.
his pulse is pretty weak. Right?
Okay. Yeah.
Okay,
Go ahead.
I'm
Call
gonna
the code, Larry. And let's
All right,
prepare.
I called the code, Dr. Harrison.
And then,
I'm working
let
on
me
the
know when you've got
epinephrine.
the epi bolus ready.
Hi, welcome to the PEA, or Pulseless Electrical Activity and Asystole lesson. I'm Dr. Larry Chu.
And I'm Dr. Kyle Harrison.
And we're going to be the co-directors and faculty for this course. So Kyle, tell me, why are we talking about pulseless electrical activity and asystole together?
Well, that's a good point. So basically, before we had different protocols for the two, but now we've learned that the treatments are the same and they're fused into a single algorithm. You basically have two pulseless algorithms. You have a shockable algorithm, and then you have a PEA asystole algorithm. And that helps keep it a little cleaner for you at the point of care. So we bundled them together in this module because the treatments are identical. There is no difference between asystole and PEA. Atropine has been removed from the asystole algorithm, so if you treat them the same, you'll do well. So that's why they're bundled.
Okay, great. Well, let's talk a little bit about the scenario that, that you just saw. Here we had a patient in the ICU.
Correct.
Who has some hemodynamic instability. The history that we get is that the patient has some chronic renal disease.
Actually on hemodialysis.
On hemodialysis. And the patient had some attempts at central venous access earlier in the day. And now we come and see this patient who's hemodynamically unstable. Let's talk about some of the things that we saw. Kyle, why don't you just talk about some of the crisis management issues from the beginning of the scenario.
So as the attending comes in, attempts to quickly assess the gravity of the situation, gets a brief sign out from his resident, but then notices pretty quickly this patient's on a pretty steep trajectory towards pretty significant hypotension. So if you notice in the anticipated plan, he decides to escalate to a higher pressor rather than neosynephrine, going to epinephrine. Asks the nurse to order that from pharmacy in anticipation, and then realizes he's probably going to need to bolus that drug to get an effect in the meantime. So he asks for a dilution of the epinephrine down to a non-code dose. Initially asked for it to be diluted down to 10 micrograms per cc.
Let's talk about that a little bit, the dose of epinephrine. Typically in ACLS and code situations, we see people opening up the Bristol-Jets and bolusing a milligram of epinephrine at a time. Now, I know it might be obvious, but let's kind of restate for our viewers why you might not want to give a milligram of epinephrine to this patient.
Okay, so this patient obviously still had a pulse. He was profoundly hypotensive, and that's an important thing to note. PEA is just profound hypotension, really the worst hypotension. So it is appropriate to use the same strategies that you would use in a PEA arrest, searching for the same treatable causes for the hypotension, using vasopressors, such as in this case using epinephrine, but you have to reduce the dose in a patient with a pulse. A 1 milligram co-dose of epi with the patient with the pulse is going to cause significant cardiac contractility improvement, but at a cost of increased demand. It's going to raise the heart rate significantly. It's going to raise the afterload significantly. So your overall myocardial work is going to increase dramatically. Your blood pressure may shoot through the roof, maybe up to 250 systolics in patients with comorbidities. That's very detrimental. So you don't want to give a full code dose. So if you're going to give a reduced dose, what is an appropriate starting dose?
So let's recap. So if the patient is pulseless,
right,
go ahead.
And give 1
give
milligram.
A milligram of epinephrine.
Pulseless is a code dose, 1 milligram.
But if the patient has a pulse, for the reasons that Kyle just stated, you don't want to go and slam them with a milligram of epinephrine. You might want to give a smaller dose, somewhere 20, 40, maybe even 50 micrograms, micrograms of epinephrine. And that usually involves having to manually dilute because epinephrine isn't stored in that dilution. It's unstable that way. So someone will have to dilute, and you saw that in this scenario, Dr. Harrison asked the nurse to dilute the epinephrine from. What is that practice of asking someone to help you in crisis management? What do we call that?
He's distributing the workload so that he can continue to monitor the situation as the patient rapidly decayed. And then as he did notice this rapid detrimental decay, especially since this patient was chronically hypertensive. So this is profound hypertension in any patient, but a chronically hypertensive, this is a really big deal. This patient's very close to having an arrest. So he went ahead and said, call for help. And then the nurse said, do you want me to call a code? And then the decision was made, yes, let's call a code. So Larry, what do you think about that?
I mean, let's talk about that for a second. I'm sure many of you watching this have been in the same situation where you're asking for help and the nurse asks you, do you want to call a code or not? And in the back of your mind, many people might be thinking, is it too soon to call a code? Because that's a big deal and all these people will be coming in. But I think it's often better to anticipate and plan. You have here a hemodynamically unstable patient who has a trajectory that's going south very quickly. And I would say it's not unreasonable to call for help when calling for a code. And what's the worst thing that could happen? You could have more help than you need. And I think in this situation that it's more than appropriate. What do you think?
Yeah, I agree. You've got to look at the gravity of the situation. Obviously, in a cardiac arrest is a high stakes event, and the trajectory where the patient's headed, rapid decompensation. You think the patient's going to get worse, you need to get the help in there quickly to intervene. And once again, all the treatments that you're going to do when this patient arrests are the same treatments you can do for this profound hypotension. So you're going to need some help there to help rule out these causes, send some labs, get a chest x-ray, eventually maybe do compressions if the patient's arrest, give more drugs. So it's completely appropriate. Don't think that that you have to be full arrest before the patient, you call the code.
That's too late at that
late.
point.
Call early enough to make a difference. It's very important. So they
great.
did, and let's see what happens.
I think we should go. Let's keep watching the scenario.
Okay, great.
Dr. Harrison, I have the epinephrine ready for you. How much do you want me to give?
Okay, the BP 68 over 35. Why don't you get 50 mics at this point? We'll give the bolus. Oh, great.
50 mics of epinephrine is in.
Okay, John, great. Go ahead and go to the head of the bed. This is a patient that's acutely unstable. That is.
Dr. Harrison, I just lost a pulse.
Okay, great. Why don't you start CPR?
Okay.
Okay, John, I want you to hand ventilate this patient on 100%. Don't overventilate. Keep it less than 10 breaths per minute. Shoot for 8 to 10. Yes, sir. Larry, I want you to push 1 milligram of epinephrine. Okay. And Anna, come around and relieve Graham because I'm going to need him to help me run the code. Great. Heather's here. Heather, go ahead and prepare 1 milligram of epi. David, I want you to help Anna with the compressions, and go ahead and hook up the monitor if you can.
Do you want me to lower the bed for you,
That'd
Doctor?
be great. Thank you, Larry.
Okay, go ahead and switch out. Graham, I need you.
Okay.
So go ahead and switch out with Anna for compression.
Okay, Anna, 3, 2, 1.
Right, so Anna, I want you to monitor the A-line. Push until your diastolic's at least 20.
I've given the milligram of epinephrine, Dr.
Okay,
Harrison.
great. Thanks, Larry. Go ahead and confirm the monitors are on. Heather, I want you to set up 40 units of vasopressin. Okay, team, we're on the PEA algorithm. I need anyone to contribute any suggestions or ideas. You got the cognitive aid?
Yeah.
Great. All right, let's check and see, make sure we're doing everything appropriately.
So you just gave him epinephrine.
Correct.
And the vasopressin as well.
I have the vasopressin. Do you want me to give it, Dr. Harrison?
let's give a minute of that first epi-NT, get it ready. And we're going to search for treatable causes. All right, so hypovolemia. Go ahead and start a fluid bolus, Larry.
Okay. Dr. Harrison, do you
Hypoxemia,
want Heather to let you know
100%.
every 3 minutes if epinephrine's going in?
Yes, excellent
Okay,
suggestion.
Heather.
Please put a clock on it. All the metabolic conditions can be ruled out with an ABG.
We can send that from his art line.
So Larry, go
Yeah.
ahead and now push the 40 units of vasopressin.
I'm giving the vasopressin.
And send a bedside ABG. We'll be
Okay.
able to rule out any of the treatable causes. One thing we do need to rule out would be
Vasopressin is
tamponade and tension pneuma, as well as what the LV is doing. Let's do a bedside transthoracic.
Okay.
I think we have a machine in the ICU, Graham. Why don't you go get that
Okay.
while we continue that. Monitoring CPR quality. John, you have the continuous CO2 connected. All right, let me know if that ever drops below 20. We're working on diastolic with the compression. Reconfirming we've had 1 milligram of epinephrine, 40 units of vasopressin, continuous compression, IV fluids are running. Okay, great. We got the bedside transthoracic echo. Let's go ahead and do a quick exam, Graham.
Okay.
Great. Well, let's pick up where we left off in the scenario. So it looks like when we got back to the scene, the nurse has the epinephrine. We already talked about the appropriate dose because the patient has a pulse at this point, and so the nurse gives 50 micrograms of epinephrine. Then what happens, Kyle?
So unfortunately, the patient continued to rapidly decompensate. Fortunately, the team was already there, so when the patient became pulseless, the team was immediately able to start resuscitating this patient with compressions. Now, if you noticed, the confirmation of pulselessness, we had many ways to confirm on this patient. Direct physical palpation, which is actually quite hard to do in most patients, but we had arterial access, so we lost the arterial waveform. We had pulse oximetry, we lost the pulse oximetry waveform, and that double combination is very confirmatory of a lack of pulse, especially in a downward trajectory like that. So
Now, when a patient becomes pulseless, the first immediate action is
compressions,
chest compressions.
CAB, as we talked about.
Okay. So you may have noticed that Graham initially began chest compressions. Why did he start chest compressions?
So he was actually the closest at the patient at that moment. So he was the first to be able to do it. However, he is the ICU resident. He is a valuable team member. He's needed by the team leader for cognitive support and also future procedures. So the team leader needed to shift him off compressions. So once an additional provider became, another ICU nurse arrived, then the team leader switched him out, and that's important. Distributing the workload, getting the appropriate person for the right task, because Graham was needed for his cognitive support as well as any future procedures, which he actually did future with the transthoracic echo.
Let's talk a little bit about crisis management, then we'll get also into a little bit about the management of PEA systole. Let's talk about leadership. So at this point, Graham is doing chest compressions, but I noticed that as the attending, you were doing something in terms of leadership by establishing yourself as a leader. Tell me a little bit about how you did that.
So there was a decision to assign tasks using people's names, getting confirmation that they understood you and their task was appropriate. I could have probably, and probably should have said, I am the leader. Granted, in this small team, this is ICU-based. I think the ICU attending is obvious to the teammates, but going above and beyond that and always confirming I am the team leader is probably your best strategy. And then they also, the leader, fostered an open exchange of information, said, team, we're on the PEA algorithm, and I want anyone to contribute and feel that they are a valuable member of this team. And then what that does is that creates a shared mental model with the team. Now everyone knows that we're operating on the PEA algorithm, and hopefully people will contribute as they see fit to this arrest. A cardiac arrest team has a lot of experience on it, but you gotta let people feel comfortable that they can contribute.
And I think we saw examples of that, where because of what you said, team members felt comfortable contributing. I know, for instance, I noticed that the nurse mentioned that we weren't timing the epinephrine doses, and should we be timing them?
Absolutely.
So those type of details and contributions from your team members can be really important.
Absolutely.
In terms of keeping a resuscitation performed properly.
And if you notice the way that that was handled, should we? Now, the nurse knew that they should be measuring that drug. Everyone on the team probably knew that, but it got overlooked. But the nurse said, should we, to the team leader, and the team leader said yes, and then confirms it. So that spoken hub model, if you will, it's going everything to the leader, then leader out to the team, is an appropriate way to maintain a single voice giving the commands. It's not telling the nurse, the pharmacist, and creating these little subgroups, which is not an effective communication strategy. So that was, I think, a very effective use by the nurse to mention that.
Well, let's talk a little bit about keeping things done properly and according to procedure. Let's talk a little bit about what the next steps were. Let's talk about the cognitive aids that were used.
Right.
So what do we do next?
So PEA is the classic arrest for a cognitive aid. The reason for that, you've got the 5 H's and the 5 T's. These are the treatable causes. So all we know is this patient has lost his pulse. We've got to figure out why that occurred. And all these treatable causes need to be ruled out. You know, if you get 9 out of 10 and the patient has a 10th of the 10th, you know, that's 90% on a test. It's 0% to the patient. So you've got to rule out every cause, and it's very important. Now, some of the strategies that were employed, a lot of those things on that aid were able to be ruled out very quickly using an arterial blood gas. So fortunately, the patient had arterial access, and that could be sent off. Another important strategy is to employ the use of bedside transthoracic echo if that's a skill set that you have. If not, are you able to find someone that has that skill set? Because that gives you valuable information. In about 2 minutes between the blood gas and that echo, you can rule off almost all the treatable causes right there. But once again, you've got to be systematic and go down them and either confirm yes or no. And in the lecture that you can watch after this, we'll go over extensively how to rule in or rule out all the treatable causes. But the cognitive aid is very useful, especially in these scenarios that require
a lot to
remember. And you know, in a crisis,
remember.
it's very hard.
Well, I think this is a good point to go back to the scenario. Let's see what they do with the echo and how they use it to help them manage this patient.
Right.
Dr. Harrington, 1 minute remaining until the next dose of opioid.
Okay, great. Let me know when it's time for the dose. Graham, how are you doing with your exam?
Yeah, so there's definitely no effusion. The LV looks pretty hyperdynamic and pretty underfilled.
So we could have hypovolemia.
Yeah.
And we haven't ruled out a tension pneumo. You did place attempt central access this morning, was that correct?
Yeah.
Have we listened for breath sounds? Let's go ahead and check for breath sounds. BP.
Bag. Okay. Bag. Yeah, they're definitely decreased on the right.
Okay, so why don't we go ahead and decompress? This could be a tension pneumo that's causing it. Why don't you get the 14 gauge IV and second intercostal space midclavicular line.
Oh, great, thank you.
Continue compression. Anna, how are you doing? Are you getting tired? If not, I need to switch out every 2 minutes. John, you're ventilating okay? Okay, great. Doing okay. Graham, you're going to needle decompress.
Yep, in the second intercostal space.
Okay, we're going to pause the epi until we know if it's the tension pneumo, because if this is the cause, we're going to have too much of a rebound with that epi. But get it ready just in case this doesn't work.
Ready.
We're going to give the other
Okay, needle
milligrams.
decompressing.
Okay. Did you hear any whoosh there?
Yeah, I got a big whoosh of air.
Okay, great. We'll see how, if that's, she was starting to get something back
We
on
have
our
a blood
A-line.
pressure now, Dr. Harrison.
Okay, continue compressions for a little bit longer till we see where this is going. We did get a whoosh. We'll need to set up for a chest tube for a more permanent decompression.
I'll call for that.
Okay, and once you pause compressions for a moment, with that we actually do
I've got
have
a bounding pulse now.
All right, so we're not going to give any more epi at this moment. We still think, let's recap team, we still think this patient is septic, arrested likely from a tension pneumothorax. Continue to ventilate. We can go back to the ventilator, John, and we will probably have to go back on the neo to support his pressure. Consider that epi. Okay.
He's got breath sounds on the right now.
Excellent. Good job, team. Thanks.
Well, so we're back. We finished watching that scenario.
Got him back, which is always
We did.
good.
It's always good when you can save the patient's life. Let's talk a little bit about that. So Where we left off is Graham was going to be using echo, transthoracic echocardiography. How can that technique help in diagnosing and treating this patient?
So it's a very powerful skill set to have. There are a lot of more places with bedside echo, the ability to rapidly assess what the left ventricle is doing. If you looked and the left ventricle is this big and barely moving or not moving at all, that tells you something. Then what happened here, for example, is a hyperdynamic and underfilled ventricle. So that rapidly told you, this heart's squeezing okay, it's just not getting the actual preload. So what's the cause of that? Is it because there is hypovolemia? Possible, but less likely, or is it a tension pneumo? If you remember, the patient had attempted central access before, that probably got lost in the hustle and bustle, and all of a sudden that reappeared as a likely diagnosis, was confirmed by auscultation, and then sometimes you can actually even see it on the echo. The other things that you can rule out with the echo, pericardial effusion, maybe massive RV strain, and maybe even a clot in the right ventricle for PE. All things that are hard to do with other signs of physical assessment, but you can if you don't have an echo.
So let's talk about that. If you didn't have a transthoracic echo, in a lot of places, let's just be honest, they don't have them. They're expensive pieces of equipment. What other techniques could? And you mentioned auscultation. What other things, signs and examination techniques could have been done to help get a diagnosis in a timely fashion?
So I think it is a challenge without this technology, because breath sounds, it's always hard to auscultate the breath sounds, especially with compressions. You don't want to delay the compressions for very long. Now, granted, if you have a high index of suspicion, you may have to pause compressions to rule that out, because if it's the treatable cause, you got to treat it. Possibly elevated neck veins, even though in the rest circumstance that's less sensitive. Maybe a tympany over, and when you percuss the chest on the affected side. On an effusion, maybe muffled heart sounds. Once again, in a rest, it's challenging. So, you have to have a high index of suspicion. Sometimes you may just have to attempt a needle decompression if you're uncertain. Once again, if you're going to have a high index of suspicion because they had a right-sided attempt of central access, I'm going to go on the right side to attempt needle decompression if I'm worried about that. But just the main thing is to continually to rule it out, because it's one of those things, if you don't rule it out, you'll never get the patient back, which is an important thing in this case. If you don't have an echo or you're not versed in that, look for people on the team that do. Call for your cardiology consults. Additional ICU fellows or attendings may have that skill set. Anesthesiologists, some have that skill set. So ER attendings, try and use all available resources, call for additional help, because it's a very useful skill to have.
Great. Well, I think we learned a lot in this lesson. You're going to learn a lot more in the lecture. But let's just quickly recap some of the principles that have been illustrated in this video. So in terms of crisis management, I think some of the things that we saw were calling for help early.
Enough to make a difference.
Enough to make a difference. And don't be worried about calling for help in a rapidly decompensating patient. Call the code so you can get those hands in time to help. The other thing we saw was some examples of leadership. I think it's important to establish the leader in a situation, to also ask for opinions and ideas from your teammates. Those things can help, and we saw here a clear example of the nurse making a valuable contribution.
Good leadership and good followership, which is an important technique.
Followership, I like that word. Now, we also saw anticipating and planning. Many examples of that. Calling for the code was an example of that. Diluting the epinephrine, getting the resources together, distributing workload. Any other
Using all available resources, so bringing in the transthoracic echo. The other important things of assigning everyone the task that's most appropriate for them, I think, was crucial. There's some science, again, that we need to review.
Let's talk about the science.
So once again, always compressions, compressions, compressions. So greater than 100, deep enough, at least 2 inches, deep enough to make a difference. And what I mean by that is that we could do physiological assessment of the CPR. So qualitative CO2, constant CO2 analysis, making sure that it doesn't drop below 10. The higher the better. Watching the diastolic pressure.
Let me stop you there for a second. You said qualitative assessment of CO2, How do people do that?
So
is that little cap thing on the end good enough for that?
So that is not. That is a qualitative, not quantitative. I'm getting confused by the terms. Here we are. So you want a number, basically. You can't just have yes or no. It's a number.
Nothing that turns red or pink.
Right,
you want a number.
Number that tells you, and it has to be continuous, because if compressions start getting poor, that number is going to fall, and you've got to improve compressions.
And respiratory therapy can help you with that?
Right, so hopefully these are now level 1 recommendations, so hopefully hospitals will be getting these in the future. You'll have to become versed on how to use them. Some transport monitors have them as part of the rapid response teams. Some ICU monitors can do that, so it's something that you need to figure out when you're at institution how to do it. Make sure that you don't overventilate, 8 to 10 breaths per minute, confirming that they're not being overventilated. Confirming that your compressors are switching every 2 minutes, giving the appropriate dose. So once the patient arrested, I'll escalate to 1 milligram of epinephrine, followed by vasopressin ×1. Search the treatable causes. Use a cognitive aid to help you remember those. One last thing you noticed at the end when the patient was resuscitated, they had gotten a pulse back, but you have to remember a lot of these patients, especially inpatient arrest, they're really, really sick before they arrest. You get them back. They're still really, really sick. You've got to continue to manage this patient. This patient is still septic with end-stage renal disease. He just so happen to have a tension pneumo, but he's still having a bad day. You still got to support his pressure. You can expect instability post-resuscitation. The post-resuscitation module, we'll talk about that, but always be prepared for more instability post-resuscitation.
And after taking this course,
Right.
you'll be well prepared
Exactly.
to deal with these issues. We'll see you the next lesson.
Great, thanks. Bye-bye.